Good morning, everybody. It's Carl. I've got everybody on mute, so this will be, I'll just kind of chat a little bit here this morning. Now, I do have the settings so you can unmute yourself if you need to speak up at the end when we do questions and answers. So today we're just going to talk a little bit about having original Medicare with a supplement versus joining what's called a Medicare Advantage plan. There's pros and cons to this, and everybody likes to have opinions on certain things. But personally, I think they're both good options, but they work differently. We just kind of need to understand the trade-offs. So to start, original Medicare goes back to the 1960s, and it has two parts. Part A, which is hospital services. That's paid for when you're working and paying Social Security Medicare taxes for 10 plus years. Then Part B, you have to pay a premium for it. The standard premium this year is $185. It's projected to be around $205 or so for next year, but the official number is not out yet. Some people do pay more than that if they have higher earnings. The federal government always looks back 2 years to determine what their IRMAA charges would be, and then they assess that. So in that situation, all the claims go to the federal government, CMS, as the primary payer. And then usually what people will do is buy a Medicare supplement to cover the original Medicare cost sharing. So I won't go over all the details on the original Medicare cost sharing. On the hospital side of it, the deductibles for each medical condition. And if you're away from a medical condition for 60 days and you're back in, it's a new deductible because it's each time for benefit period. And then there's a deductible around $1,600 for the first 60 days, and then it goes to a daily rate after that. So a long-term hospital stay on original Medicare or multiple medical conditions can make Part A on its own kind of expensive. Part B, the deductible's pretty small. It's only $257, but then after that you pay 20%. That's where it can get people because there's no limit on the 20%. So Medicare supplement insurance is designed to cover that Medicare cost sharing. Now, the advantages to original Medicare with a supplement is there's no networks. It's any doctor, any hospital, anywhere in the country that takes Medicare. And the federal government, since they're the primary payer, they don't have a lot of managed care programs like commercial insurance through employers, Medicare Advantage plans. Most of the stuff that's out there has managed care programs where there's networks to work within. Some things might need to get pre-approval, pretty standard stuff that we've become accustomed to. That exists on the Medicare Advantage side. There's not a lot of it with the original Medicare and the supplement. So original Medicare, freedom, open to go wherever you want, as long as they take Medicare, and comprehensive because it fills those gaps in original Medicare. The downside is the price that we pay to get it. And the rate increases the last couple years have been higher than what I've seen in the previous decade. They've been trending like 11 to 8% a year on the last couple years. The previous decade, it was more like in the 6 to 8 range, and that's across the board. It doesn't matter the insurance company. They're all saying the same thing. The claims are at an all-time high, and the frequency of which we're seeing large claims is at an all-time high. So the insurance companies' claims are up. They have to spend 85% of the money that they collect on claims and quality improvement projects. So their margins are tight. So then they just adjust it out and they push it back to us. And as consumers, we pay the higher premiums, just like auto insurance and homeowners insurance. So that's what's going on, advantages to original Medicare with a supplement. And then you buy your drug plan separate, and that's going to go, those are anywhere from 0 to 125 a month on top of the supplement premium. The plan that people enroll with for Part D is case by case. Each person has their own meds that they take. Each plan is going to have a different way that they're going to cover them. So we do an evaluation to determine which plan is going to have the lowest total cost between premiums paid in and then the out-of-pocket spending for the year. And then we help people find that most cost-effective Medicare Part D plan. And then you got to buy dental and vision separate as well. So that all adds up. It's not unusual for people that have original Medicare with a supplement, the Part D plan, and their dental and vision, when you add up those three components, depending on their age, they can be anywhere in which plan they have 225 to 400 a month. It can be in that range. So they're paying a higher monthly premium to have the lowest out-of-pocket exposure available. Another thing that's happening in the industry is a few years ago, there was legislation passed called the Inflation Reduction Act, which required a $2,000 cap on Medicare Part D spending. Um, but the government funding is not keeping pace with the claims on that side either. So the insurance companies are adjusting out Part D, rearranging formulary lists, increasing premiums, adding deductibles on, things of that nature to adjust it out on Medicare Part D. And a lot of the carriers, what we're anticipating is they're moving to zero commission for brokers because they're not making much of a profit on Medicare Part D. And in fact, a lot of them are losing. So they don't want to pay agents to bring them a product or a customer that they're not going to make any money on. So that kind of puts us in a little bit of a awkward situation because I have to either pay people to do my Medicare Part D reviews, and then you're paying somebody, but you're not getting any revenue to offset what you're paying them. Or myself, I can do it, but then I got to be careful with time because during enrollment season, I got more people that I want to talk to me the hours in the day to handle, which is a good problem to have, but it's a lot to handle in a short period of time. So we're trying to, I've come up with a plan on how to do coverage reviews for people that have Medicare Part D by itself, and that's using that Retire Flow platform where we've been sending out a link. People can click on it, enter their meds. It goes into our review queue based on, and we're working at first come, first serve. And then we sort it out, find the plan that has that lowest total cost, send it to the member through the quoting tool, and then we're going to send them a follow-up email saying, hey, we just sent you the quote. It came from this address. Here's how to review it. And if you like it, put it in the cart and apply yourself. So we're trying to make this a two-way street to streamline the process of doing Medicare Part D reviews because it's not commissionable to us. So we want to make sure that our clients are taken care of, but we got to figure out how to manage the time. I do have a silver bullet, and that's Jennifer Lishing, my wife of 25 years. She works for the right price. I don't have to put her on payroll, but she works for kitchen renovations and vacations and things of that nature. So she'll be the main person doing the Medicare Part D coverage reviews and helping people through that process. So that's a little bit about original Medicare, supplements, Part D, dental and vision. Now, on the flip side of it, what I'm seeing in the industry because of these increases in the Part Ds, the increases in the Medicare supplement, sometimes increases in the dental and vision based on claims experience, is people are starting to feel the squeeze on their monthly cash flow. Now, for people that are comfortable paying those premiums and they want that more comprehensive coverage and that freedom that comes with original Medicare, and they're able to handle the premiums, I say stay with it. But if they're getting the squeeze or they understand the trade-offs of moving to Medicare Advantage, because it is a cost-effective solution over time, then maybe we look at Medicare Advantage closer for each person. Now, on the Medicare Advantage side, this thing financially, it's called pay me now or pay me later. So original Medicare with the supplement, you're paying the higher price to have the lowest max out of pocket. An Advantage plan is going to be the opposite. So monthly premiums can be as low as zero, but you're going to pay as you go through the form of copays and coinsurance, and there's a high-end limit. In the middle is we look at Medicare Advantage, where there's those copays. A lot of them are small, but they will be going up next year. For the copays and out-of-pocket limits are going up. They'll maybe cut back on some of the extra benefits because the funding isn't keeping pace with the claims. And again, the money's not growing on trees. So the insurance companies will rearrange the benefit structures and the copays to balance out those claims. Now, there are supplemental products that have grown in the market that with Medicare Advantage, we go down the list and we look where the bigger copays are, like hospital stays, outpatient surgeries. expensive drugs administered in the doctor's office, like injections, infusions, chemotherapy, long-term skilled nursing facility stays. And then there's supplemental products that can be purchased that pay cash directly to the member to offset that cost sharing. And depending on how we structure those supplemental products, they can be anywhere from $30 to $90 a month, depending on the age and the benefit design. So you put that alongside of a zero premium Medicare Advantage to complement it and balance it out, and the two kind of work together to provide comprehensive coverage at a price point that's not as much as having original Medicare with a supplement. So that's kind of like, instead of going all the way down to Medicare Advantage by itself, that would kind of be like the midpoint. So you use Medicare Advantage and you balance it out with supplemental health products. So Medicare Advantage is the pay me later story. So you hold on to your money, you don't give it to the insurance company, you build your cash reserves, and you pay as you go. And I'd say for a lot of people, when you take that into consideration over time, 5 years, 10 years, 15 years, 20 years, 30 years, whatever life expectancy happens to be, it is cost effective. There's another thing to consider though about Medicare Advantage, and that's it is managed care. So there's pros and cons to managed care. It exists everywhere in our society with group health insurance, under 65 individual health like ACA plans. So private healthcare companies have managed care developed in the 80s to better control cost and outcomes and making sure that they're paying for things that are medically necessary and just not getting billed for everything and running up the charges. So there is review processes. So there's networks to work within. Networks can either be HMOs or PPOs. HMO is not a bad word in the Medicare space because the networks are big. They're usually very similar to the PPO network. The difference is on an HMO, you have to stay in the network to be covered unless it's an emergency. On a PPO, you can go out of the network, but you pay more. Now, most people don't want to pay more, so they don't go out of network anyhow, but you do have that choice to go out of network for non-emergencies. Now, because the insurance companies have to account for the higher cost of an out-of-network claim, the benefits on a PPO, when you go through and you look at the copays and the max out-of-pocket and the dental and the vision, generally speaking, the benefits on a PPO are not as strong as the benefits on an HMO. So HMOs prevail in our market, like Northeast Ohio. It's a good market for Medicare Advantage because we have a large enough population to support it. Some of the rural markets, the products aren't as good because there's not as much enrollment numbers to make the numbers work. So there are those networks, HMO or PPO. And again, HMO is not a bad word, but sometimes people get that in their head, through the 80s and 90s. And when those things first came into play, the networks were really small and people didn't have a lot of choice. That's not quite the case these days. And most of the plans don't require referrals either. So you don't have to go to your primary care doctor and get referrals to see specialists like the old days. So there are managed care programs. Now that's pros and cons here. Managed care is more proactive at reaching out to members and engaging them, encouraging people to do wellness exams. They offer home health visits, and the nurses will come out to the house, check things out, observe the living environment. And if they see trip hazards and somebody's walking around with a walker or a cane, they'll address those things. So it's more proactive on controlling the controllables and keeping the person healthy to help minimize the bigger claims. So early disease detection, blood pressure, cholesterol, if those things aren't under control, that's heart attacks and strokes waiting to happen. So they try to encourage the preventative care. And then when things need to be done, the doctors and hospitals might need to coordinate with the plan and get prior authorization. That responsibility does not fall on the member. The doctors and hospitals have to get it done. But sometimes the insurance companies will require prior authorization to review it, make sure it's appropriate and it's medically necessary. And they have medical teams that review those things there. So it's not just the bean counters making the choices. Another thing I've noticed with Medicare Advantage plans, is Medicare Advantage as well as Medicare Supplement, they pay for rehabilitation to get people better. That's called skilled care. Neither one of them pay for what's called custodial care. That's when people are not getting better, but they need help with activities of daily living, like bathing, dressing, transfers, mobility, eating, using the toilet, medication management, when cognitive function declines, dementia, Alzheimer's, those kind of things. So neither Medicare, original Medicare, or Advantage plans pay for that. That's another topic that we'll touch on when we wrap up. The original Medicare with the supplement generally requires a 3-day inpatient hospital stay first, and then skilled nursing facilities are covered up to 100 days. And as long as that skilled nursing facility is billing for skilled care, and they will find a way to bill for skilled care and perform it, even if the person's not improving, they will cover up to 100 days. But then after that, there's no more. So people might have a little bit more time of that skilled nursing facility being paid. And from personal experience with my family, I watched it happen with my grandmother. She was there. She was ready to come home after about 20, 25 days, someplace around there. But my dad wasn't ready for her to come home yet because he's going to be the caregiver. So he kept her in there as long as he could, that 100 days. And then she came home after that. So it bought him a little bit of time. Now on Medicare Advantage, because there's managed care, they're looking at the patient progress and how they're doing. And if they're going through rehabilitation and they're making progress and getting better, they'll authorize more days. But if they've plateaued at that point and they're not getting better, it's no longer skilled care rehabilitation because they're not getting better. So they might not authorize more days. Or same thing with the physical therapy side of it. They look at it and they pay for the things that are appropriate and medically necessary, but they're trying to better control the spending and the patient outcomes. So pros and cons to that, but that's the way the system works on Medicare Advantage. So in summary, pay me now or pay me later. And then Medicare Advantage has managed care. Original Medicare doesn't have much. And then Medicare Supplement, you're paying that higher price. Medicare Advantage, you pay as you go. And then in the middle, we can add some supplemental products around those Medicare Advantage plans to balance out the bigger copays, and those can work together. So that's pretty much it as far as the pros and cons of original Medicare with a supplement and Medicare Advantage. One thing here before I open it up for questions and answers is life lessons, living, dealing with aging parents and things of that nature. I've learned that there's 4 legal documents that everybody should have, and I'll share them with you guys to make sure that you have them. Healthcare power of attorney, a financial power of attorney. So if somebody's health takes a turn or their cognitive function declines and they don't have the ability to pay their bills, schedule their doctor's appointments, you're assigning that over to somebody that you trust to handle that stuff for you in advance before you need it. Then there's living will, also known as an advance directive. That's your wishes. Like if I'm hooked up to a machine and I'm not getting better after a certain period of time, pull the plug, do not resuscitate orders, whatever you want in there. That way you're making that decision for your family. And then they're not forced to make those decisions at a bad time, because I've run across some people that have made those decisions, and then they might have some doubt or second guess if they made the right choice or not. So you're not putting that on them. You're making the choice for them. The 4th legal document is last will and testament, which is basically your instructions on how to distribute the estate when it goes through probate process. Probate, because none of us get out of this place alive. And what I've learned as an advisor working in this industry for a while is people like to plan for the things that they're looking forward to, like their retirements, their vacations, time with family and friends. But a lot of times people don't plan for the things that they're not looking forward to. And the aging process and the inevitability of death could fall into that category. Who wants to think about it? But it's going to happen. So the population over 65, 70% of it's going to need long-term care. That's a pretty high probability. 100% probability of death. I didn't have to source that one. I just kind of figured it out. But that 70% probability on a long-term care claim, that's coming from the Department of Health and Human Services, the United States governments. So it's a real issue. And then I think we need to plan for it with 70% probability that if you need care, where is it going to happen? Who's going to provide it? How's it going to get paid for it? Because a lot of times people say, I want to be in my home. If you need round the clock care, there may be family members that can help if they're available, willing, and able. But then we got a question of, do we want to make our family members the caregivers? Personally, I don't want my kids to be my caregivers. I want them to live their life to the fullest. That's the number one motivator. Number two is I don't want them to have to clean me up down below if I can't take care of it myself. And I'm guessing they probably don't want to be there either. So if we want in-home care, that's 20 to 25 bucks an hour. So if you start doing round the clock, it's over 200,000 a year. Assisted living facilities, a decent place is 8 to 10,000 a month. Some of them are more. On the lower end, 5,000 or so, but the environment that you're living in and the people that are there, it's going to be more of like oftentimes the Medicaid population. So you got to think about home. I remember my dad saying that I want to go home, but he didn't have the resources to pay for round-the-clock care. We're being told that's what he needs. My sister and I aren't available to do it, or my brother, because we're in the workforce. So it starts putting, the family into a difficult situation, trying to figure out what's going on. And sometimes these stresses on the family unit at that time can cause emotions to escalate, and then people start fighting, and then the family unit blows up because they're trying to figure out what to do in a stressful time and they don't know what to do. So we should plan ahead for these things, and then how are we going to pay for it? And what resources do we have to pay for care? And what resources do we want to protect from the cost of care? And there's different ways to protect resources. Things can be done with legal work using trust to put stuff over there. Now there's a look back period on it. After 5 years, it's fully protected. I'm not an attorney, but I know one that I network with that is good at helping people with that stuff. And then there's insurance products that we can get to help pay for care. And there's entry-level home health plans that can be used to provide some caregiver relief for family members so they can get out of the house and get a break and do things. Those little home health care policies, there's affordable, $60 to $100 a month. So it's attainable for most people. And then there's short-term care policies. They can be used to help transition. Some of the decent assisted living facilities want people to be private pay for a year or two before they'll bill Medicaid. So the short-term care policy can be used as a way to bridge that, and it's more affordable than a traditional long-term care policy. And then there's some life insurance hybrids. So by partnering with an insurance company, you're able to use their money, because if somebody's in assisted living, you're 10,000 a month, you're paying 10,000 a month. If you have some kind of insurance product, you can leverage your dollars and use the insurance company's money if you need it, instead of having it all fall on you. So I bring this up because sometimes people don't know that we deal with this stuff, but I can help people with this. It just involves a little bit of advanced planning. So you got to think a little bit about how you want it to go down for you and your family, and then plan in advance for it and get your ducks in a row so they're not dealing with the stressful situation. So I think planning in advance for this topic here, it does a few things. It helps protect family relationships. It protects assets and resources if there's a desire to do that, and it helps protect our legacy of how people remember us. So if that's something that people want to talk about, just shoot me an email at carl.lishing@healthmarkets.com. That's carl.lishing@healthmarkets.com, or call the office 216-228-0765. Those planning sessions, I don't do those in October, November, December for obvious reasons, because we're just trying to keep up with open enrollment season. But I'm happy to have those conversations outside of enrollment season for people that want to plan.